Dear colleagues, in partnership with the Deutsche Gesellschaft für Nephrologie, the Österreichische Gesellschaft für Nephrologie, and the Société Francophone de Nephrologie Dialysis Transplantation, Marcus at Home welcomes Dr. Nilufar Mohebbi in Zurich, Switzerland, and Dr. Navdeep Tangri in Winnipeg, Manitoba, Canada, in order to discuss when to treat renal acidosis in patients with chronic kidney disease, CKD, based upon their PRESERVE-Transplant and VALOR-CKD studies, respectively. Dear Dr. Mohebbi, dear Dr. Tangri, it's a pleasure to host the two principal investigators of two landmark trials in the field of CKD. Thanks for being with us.
Thank you so much.
Thank you.
Dr. Nilufar Mohebbi is physician for general internal medicine and nephrology in the NephroCare Dialysis Centre Zurich-City and professor at Zurich Kidney Center at the University of Zurich. She has done basic science research on tubular diseases, including renal tubular acidosis, which stimulated her to initiate the PRESERVE-Transplant study in Switzerland. Dr. Tangri is an attending physician and professor on the Division of Nephrology, Department of Internal Medicine, and Department of Community Health Sciences in the Rady Faculty of Health Sciences at the University of Manitoba. Dr. Tangri's research program focuses on improving clinical decision-making for patients with CKD or at risk for CKD. And hopefully all of our nephrological colleagues know and apply his kidney failure risk equation, which predicts the need for dialysis in patients with CKD, and which we discussed back in 2021. And while Dr. Tangri remains engaged in implementation efforts with guidelines, lab providers, and EMRs to increase the uptake of the kidney failure risk equation worldwide, he also leads large observational studies and randomized trials in CKD, and including, surely with regards to today's talk, VALOR-CKD. So again, thanks so much for being with us. I'm very happy to have Markus Seelmann from Vienna as my co-moderator.
Wonderful. So from 2017 to 2022, right from the beginning of the VAVERMER program, it was a pleasure to be a part of and then eventually lead the VALOR-CKD studies. The studies were motivated because there was a clear sort of unmet need in treatment of acidosis, and we did not have clarity, to me, because we did not have double-blind randomized trials. What we had was a suggestion of positive outcomes from single-center unblinded studies, and that was largely the motivation behind VALOR. I think the second motivation behind VALOR came from the lack of approved treatments for metabolic acidosis. So if you assume that metabolic acidosis was harmful, and there was certainly ample physiological data to assume that metabolic acidosis was harmful. There's data from Dr. Weston's lab and others showing that increased ammoniogenesis leads to fibrosis, and there was also data from Dr. Bashinsky's lab about bone disease. There was data from others. I think Bob, Roche, and Ravin published some data on muscle energetics with acidosis being impaired. So there was all this data suggesting that this is really a good thing to do. The only treatment off-label used, so off-label means not approved by the FDA or not approved by the EMA, was sodium bicarbonate. And at least in my experience, and I'm happy to reflect back to the group here, my clinical experience was that sodium bicarbonate caused GI intolerance in not a significant, not a small minority, but a significant minority of my patients. I never really saw too much of the edema and the salt-sensitive parts of sodium bicarbonate, but I definitely saw GI intolerance and pill burden. So VAVERMER, had an elegant mechanism to deal with that. So let's go a little bit into the mechanism and the background of what develops the drug. So VAVERMER is a polymer like patiromer, which is a drug, that many of you may be familiar with. That irreversibly binds hydrochloric acid in the gut. And when you bind and trap hydrochloric acid, you generate base. It's equivalent to vomiting without the loss of fluid. So it was fairly elegant. It leaves nothing behind. So you bind the hydrochloric acid irreversibly, you excrete it in the bowel, in the stools, and in previous studies, there was a study called the 101 study, which was published in CJSON, which has some background, and there were studies in Lancet, too, published from Dr. Wesson and colleagues, showing that treatment with vivarium raised serum bicarbonate by 3 to 4 milliequivalents per liter. And at least in the last sort of phase 2b/3 study, there was a sense that perhaps there were better clinical outcomes. For sure, there was a clear signal about sit to stand time and self-reported physical function, and perhaps a hint in small numbers that kidney disease outcomes were also improved. And that's what led us to VALOR. The next thing I want to go into is the design of VALOR. So VALOR was a randomized, double-blind, placebo-controlled, multi-center trial. It randomized 1,480 patients, older adults, 740 to vivarium and 740 to placebo. The final numbers ended up being 741 and 739. Most patients were on the maximum dose of vivarium by the end of the study. There was a titration protocol, and the eGFR criteria were 20 to 40. And the bicarbonate criteria were 12 to 20. And these were selected because it was mimicking the previous Lancet studies. You wanted to stay as close to the previous studies in the program as possible because of, again, largely regulatory reasons. The primary outcome here, was a real outcome. It was 40% decline in GFR, kidney failure, or death due to kidney failure. So it's all renal outcome. So no CV death in here in the primary outcome, no cardiovascular or all-cause mortality. The reason 40% was chosen, just very quickly, is because we would not expect a drug like vivarium to have any acute effect on eGFR. And neither in any of the previous studies, we didn't see any hemodynamic effect up or down on eGFR. So you pick 40% because you get the same or better power than a 50% or a 57%. That's been shown in other large studies. It was a time to event study, and the goal was initially to go out to almost, I think, 500 outcomes. And then at some point, because of financial reasons, the company felt that they could not carry the trial all the way till the required sample size and the outcomes. And there was a decision made from an administrative perspective. And this is not the first time this has happened, by the way. So this has happened previously in, for example, the sotagliflozin program, which had the scored studies, which were published in the New England Journal as well, the company decided to go as long as possible. So the point was to go as long as possible with sufficient time to interpret and publish the results before running out of resources. And actually, the target was to achieve at least 250 outcomes before stopping, because that was roughly equivalent to a hazard ratio of 0.76 to 0.77 detectable. And we ended up getting about nearly 300 events. I think there were about 280 events or so. And 297 total. And then so that ended up giving us a hazard ratio of almost 0.8 that was detectable. So I think we all felt pretty good that we had enough power to find an effect that was at least roughly 0.8, okay? So in that sense, I don't think we stopped too early or stopping early had any effect on the outcome of the trial. Other secondary outcomes included, the composite of the outcomes, all-cause death, cardiovascular events, chair stand, and physical function. The study was during the period of the study, patients went through two parts, a part A and a part B. So now I'm going to describe a little bit about part A and part B. So the study had a randomized withdrawal design. It was trying to enrich for people who respond to vivarium. And from the previous studies in this program, we had felt that 3 out of 4 patients would respond to vivarium and have a big rise in their serum bicarbonate. In the final larger sample, that ended up being 2 out of 3, or about 66%. So still the vast majority respond to vivarium. And it was felt that by enriching on this response, we could get a greater separation between patients who are on drug and placebo. Again, run-ins, prognostic enrichment, all of this is not unusual for large phase 3 studies. Then there was a randomized withdrawal. So it was felt that patients who responded would then be withdrawn in a randomized way. So they would either continue on vivarium in part B, or they would move to placebo. So at that point, what happened was we were expecting a decline back to the baseline. So a decline of 3 to 4 milliequivalents per liter back to placebo in those patients, in the patients who were randomized to the withdrawal and return to placebo. And that's what we had seen actually in the Lancet studies that were published previously, that after you stop the drug at week 52, there was a precipitous decline in bicarbonate within about 2 weeks. So this was not, again, a first time that this type of experiment was designed. We had seen this previously in the 200 patient study. Unfortunately, in VALOR, this did not happen. So the patients did not drop 3 to 4 milliequivalents per liter, and they only dropped about 0.1, about 1. And so the separation between the two groups remained quite small throughout the study period. And so what happened is you had about a 1 milliequivalent per liter separation throughout the study period, and you saw no difference in clinical outcomes for any of the outcomes, including physical function, including time to kidney failure, and so on. So in the end, we have a negative study that shows no effect. And I think here's where we're sort of getting into sort of strengths and limitations of the study. So first, truly multi-center, truly double-blind, large representative population, truly the people with acidosis that you want to treat, 12 to 20. And it's a null result. So this study does not support treatment of acidosis in people with CKD. Now you could argue and say that the difference was only 1 milliequivalent. Does it really allow us to say anything about treatment of acidosis? And I think I'd love to hear from Dr. Mohebbi here as well. But to me, this is not the only study. You have to put it into context of all the studies of treatment of acidosis. And then I would challenge the readers or the listeners today to think about a randomized double-blind study of treatment of metabolic acidosis that's well done, free of bias, that's actually positive. And you won't find one. So that's really what it comes down to. So to me, VALOR is quite meaningful because it definitively creates equipoise for metabolic acidosis now. So when we did VALOR, we had pushback from REBs, actually, interestingly, especially in Germany, we had a lot of pushback from REBs saying, how can you randomize to placebo? Well, I would say in the post-VALOR era, you absolutely should randomize to placebo because we have no evidence that treatment of acidosis improves clinical outcomes. So I think VALOR opens the door for future studies of acidosis at any range of bicarbonate, really, to randomize to placebo and do well-done, well-conducted studies. And I think other studies, while VALOR unfortunately did not have a large difference in bicarb, other studies that are randomized, double-blind, have shown a 2 to 3 milliequivalent difference in bicarbonate and not found any difference either in clinical outcomes. So I would say perhaps you got to aim higher, perhaps you've got to do it differently, but at this point, it's total equipoise. So I'll leave it there and look forward to the discussion with all of you.
Yeah, thank you very much, Professor Tangri. You say post-VALOR area, so I think it's a large contribution that you have made. I have learned from my former boss, and everything was expert opinion, what he said. Drive them up, the CKD patients, till 25, 26 millimoles. It is simply good for the whole organism, so to say, from bone to kidney. Yeah. And all these monocenter studies were supportive for this thesis, and now the times are different with VALOR. But coming to the study itself, have I understood it correctly? You got the patients between 12 and 20 millimoles of bicarbonate, so this was somehow an idea of the bicarbonate. And I don't know the daily fluctuations of serum bicarbonate. So thinking of a continuous variable, was this some kind of regression to the mean that you then figured out these patients?
So you make a really good point. So first, I think let's open up our imagination to the idea that perhaps bicarbonate is not the best measure of total body acid-base status, right? Because really what we're measuring is one compartment There's a respiratory compartment, there's an intracellular compartment, there's things that's happening in the bone reserve. So I think the first notion we have to say is that in practice, we treat metabolic acidosis and CKD reacting on serum bicarbonate, but in reality, is serum bicarbonate really the best measure? I don't know. I don't think so. There is variability in serum bicarbonate. And in fact, if you treat, so Julia Ciala, I think, has done some like closed center studies where they keep people, in a research center overnight for a couple of weeks, and you give them bicarbonate or you give them a diet. Even in those well-controlled experiment, basically the change in bicarbonate has one standard deviation. So if the change is 2, the standard deviation is 2. So people are, going from 0 to 4, even on a very well-controlled experiment. So it's a big range. I think that's one thing I really want to open up. I think in VALOR, my most likely explanation is regression to the mean, because I think what we did in part A was that we put a lot of selection pressure on the bicarbonate being low. So we required 3 measurements between 12 to 20 in a 6-week period. And at that, I think what I learned after VALOR was that acidosis is probably, or acidosis as defined by bicarbonate, is probably a transient phenomena that happens in our patients. So our patients probably have periods of acidosis, and then they go in and they go out and they go in and they go out. And I think we caught a lot of people when they were in their acidosis, and then they go out as they kind of enter the trial. And unfortunately, I think that there's even our technique of measuring bicarbonate is not perfect, right? Like if you imagine your tourniquet is left on 30 seconds longer, you get a slightly different value, right? So there's a number of reasons why I think regression to the mean is the most likely explanation why the randomized withdrawal didn't work out.
This is a very good point, so that we have a proxy, which is maybe unspecific for the regulation of bicarbonate within the body. I mean, there are even studies showing that there is actually, for example, a potassium deficiency in dialysis patients because we do not take care of all the composites and regulatory pathways within an organism. And on the other hand, maybe then we should need something like an HbA1c of bicarbonate. There's an integral, for example, and we could, like we would select on a single blood sugar measurement the patients and treat them with some kind of antidiabetic.
Yeah, I mean, I think Don Wesson, who I worked with a lot on these trials, talks a lot about urinary citrate, which is a marker of sort of acid stress, and we talk about the concept of net acid stress. Unfortunately, some of those markers are not at a stage where we can measure them in a multi-center, multinational clinical trial with a lot of accuracy. So an A1C type measure would actually be perfect if you could measure 3 months or 6 months of acid stress. So interestingly, you mentioned this. So we are doing other studies in acidosis now, like in federally funded grants, and what again, just learning from VALOR. So some of the things that we're trying to do is we're saying, use local labs and look back at least 6 months and make sure there isn't a single value above your threshold in the last 6 months, because you want to see that truly this is a person with chronic acidosis, not somebody that's going up and down and up and down. And again, in VALOR, this was not possible because in many, many countries, serum bicarbonate is not a part of the standard metabolic panel. So it was not available even from local labs. So we could not have done this in VALOR because it had to be done with ISTAT in the trial. It was just not available in local labs.
Okay, because we are enforcing, at least in our country, in Austria, that nephrologists should also work outside of the hospital. And in our health insurance hears this, they say, we do not need any blood gas analysis, maybe. So breaking it down for our viewers, which like to draw practical points of our discussions, what should we do now with a patient who is below 20 millimoles, a CKD patient?
So great. So I think that this was nicely discussed, and believe me, it reached a lot of discussion at the KDIGO-CKD guidelines. So both VALOR and Dr. Mohebbi's trial and other trials were discussed heavily in the KDIGO-CKD guidelines. And I think the guidelines have taken the right approach, which is they've said that we cannot make a recommendation on the treatment of acidosis, which reflects the equipoise in the field. We can make a suggestion, which is really a practice point, to say consider treating. So if you want to treat, you can consider treating below 18. And even that was felt to be purely opinion-based and largely just, I think, a bit of a reaction to a lot of our excellent nutrition researchers who spent a lot of time studying metabolic acidosis. But in no way, I think, does this enforce. So I would say, look at the number of drugs we have that actually change patients' trajectories. We have RAS inhibitors, we have SGLT2 inhibitors, we have MRAs, we have GLP-1 agonists, we have drugs that treat blood pressure. All those things actually improve clinical outcomes. Sodium bicarbonate, which you need 3 to 6 pills a day, does not improve clinical outcomes. So if I'm a physician, I'm choosing one of the 5 categories of drugs that I mentioned over sodium bicarbonate almost every time, because I'm going to have to make a choice with my patient to say, how many pills am I going to ask you to take every day? Right? I'm not choosing a phosphate binder. I'm not choosing sodium bicarbonate. I'm barely choosing anemia treatment, because even that, as we know, is not so simple. But I have 5 drugs. I have 4 disease-modifying drugs plus treatment of hypertension that actually improve clinical outcomes. So that's what I would say to the listeners.
And maybe there's the action bias that all physicians have. We have to do something.
Yes.
But maybe a minor thing would be the patient who is on such a panel of drugs which are more on the risk of hyperkalemia, except from SGLT2s. And if they're really low with their bicarbonate, maybe there's some buffer that they don't get into the hyperkalemia side. But this is all.
Okay, so we're going to get to, you led me there unintentionally, to the most interesting physiological finding of all of this Vivarimer program. So in the Vivarimer program, even in the studies that raised bicarbonate by 4 to 5 milliequivalents, there was 0 effect on potassium. So I actually think treatment of acidosis does not change hyperkalemia. Sodium bicarbonate changes hyperkalemia, because you give a sodium load, you give a bicarbonate load, that sodium gets excreted and it gets exchanged for potassium. So if you are treating hyperkalemia in someone with acidosis with sodium bicarbonate, it's not really the acidosis that's changing the hyperkalemia. It's the sodium and the bicarbonate. So this was a very remarkable finding. Across the entire program, even when people's bicarbonates went way up, the potassium did not even change a single decimal point.
Okay, so we stick to giving bicarbonate.
Yeah.
Gunnar, what do you say?
Well, I have 2 questions directly on the study. So the first one would be, if one looks at the time course of bicarbonate, it looks as if at the end of your trial, the 2 curves somewhat diverge. Is this just because the number of patients become lower?
Yeah, so I think 2 things going on exactly. So first is the number of patients are lower. 2 is that their kidney function continues to decline over time. So they have less and less reserve. So the ones they're becoming more and more acidemic. And perhaps being on Vivarimer is keeping them, keeping the treatment group a little bit higher than the group who's on placebo. I think that speaks a little bit to total acid load, and bicarbonate, is maybe a late marker of acid reserve. Maybe it only falls off once your base reserves are exhausted. So those are the 2 possible explanations. I agree.
And then at the other end of the study, at the very beginning, so this first run-in phase, did you also do this in order to identify those patients who are more or less compliant to, or did you really expect some
2
people?
reasons. Yeah, those are the two reasons. The first reason was adherence, right? Because it's a binder, it's a polymer, it's a powder, you have to take it, and some people don't like taking powders. This was a very easy to take drug, by the way. It doesn't taste like anything. It's like pateramer. And then the second was to select for people who respond quickly to get a large delta. The goal was to get a large delta between the two groups in bicarbonate. Yeah.
Okay. Then I would love to add two questions on the kidney failure equation, which is
Sure.
not really within this field, but since we have you here and since
Sure.
you had you here 3 years ago, and things changed so dramatically in the last years. So we have a couple of treatment strategies which fell out of our favor, like bicarbonate, surely. We have others like SGLT2 inhibitors, surely, and a GLP-1 agonist. So does the kidney failure risk equation require an update, or can we still go on with the one calculation that you published 10 years ago?
Yeah, so really excellent question. So we initially developed the model in 2011, then we validated in 2016, and then we last did one in 2021. The issue is that we plan to update at least, I would say every 5 years, we plan to update and check if it's still accurate or requires recalibration. I think the main challenge is that for us to recalibrate to the new drug era, we need sufficient number of patients who are on therapy, probably 50% plus on SGLT2 with 5-year follow-up. And we just hadn't gotten there in 2021. So I think probably in 2026 or 27 update, we will have that, and then we should. All equations should be updated over time. So totally agree with you. Excellent point.
So, and if we use your calculator online right now, we don't have anymore the numbers from 2011, but we have these updated numbers then in the...
Yeah, we try to keep it always updated. We have not felt there hasn't been a change, or a change has not been required at the last check in 2016 or 2021. Same either from competing risk we've checked from other, like the introduction of new therapies. A change has not yet been required, but we do check because I believe that you need to update equations over time.
My last question before switching then to Dr. Mohebbi, and also asking Dr. Mohebbi first, since she did all this also basic work in physiology, whether or not we already have maybe some kind of a long-term predictor of acidosis. But I would first, Navdeep, love to hear from you. So how annoyed have you been? It's a personal question. How annoyed have you been to see the first two studies, the short-term studies to see in the Lancet, and then the long study to see in JACE, which is still surely a great journal, but it's no longer the Lancet. So what does this tell about publication and the willingness of journals to publicate negative and positive studies?
Yeah.
And I'm aware that the Swiss study has been published in Lancet, even though it's a negative study.
Yeah, so thank you for that. I think that's a clear bias in journals for negative studies. I will say this out of the open. I think that, and this sort of needs to stop. I think that studies you do not absolutely have no control over the outcome when you design a study. If we did, all the studies in the world would be positive. So I felt that every time I've had a positive study that I've been involved in, I've had a much easier time getting it published. And I think that that's a message for journal editors out there who, unfortunately, many journals I think are equally interested in what's a press-worthy finding than what's a scientifically worthy finding. And I think this gravitational pull towards having the press or media pick up your journal article is bad for science. And I think that we should continue to publish the best science, the more impactful study. Any study that changes a clinical practice guideline should be published in a high impact journal, because that means there was a study that moved the field. Right, because that's the guideline is now going to reverberate across global practice. So I think that I completely agree with you, and nice to be able to call out the journals on your on your video cast.
Thank you. So Dr. Mohebbi, before switching to transplant patients, two questions again based on your earlier work. So is bicarbonate in plasma really the best strategy to measure in clinical practice, or do we have better approaches? And then surely again, what is your take of the CKD study by Dr. Tangri? So outside transplantation, again, CKD, do you agree with this? Well, not recommendation, but practice point to consider giving alkali treatment once bicarbonate falls below 18 in our patients?
Thank you. Thank you first for the invitation and the opportunity. And thank you, Dr. Tangri, for this wonderful discussion of your paper, actually. To your first question, so regarding a better parameter, you know, we have always the dilemma, and Dr. Tangri already mentioned, about parameters that are like available at any lab or even maybe on the bedside, or parameters that we use actually for basic science research that we can measure in the lab, but are not like usually available in huge laboratories. However, and he also mentioned, Dr. Wesson, he has brought in a new term of bicarbonatemic acidosis, which means that you have even low bicarbonate levels, but we know that the bases are already reduced in body. And this is not only citrate, we more trust in ammonium, because if the whole acids that we excrete by the kidneys is like the net acid excretion is defined by ammonium and some other acids that are very low, so 90% is ammonium. So if we would be able actually to measure ammonium excretion in our patients, that would be probably a better or a more precise parameters. So we did it in transplant study, and I was lucky to have also a biobank. So I have samples from all the collection time points, and we will, of course, analyze these data. We have not done it yet, but we will do it. It's now currently actually one of our projects. And I think that was also one part why I did this study in that way, that I also wanted to understand a lot about, or a bit more of the pathophysiology, and not only just to see if alkaline is helping or not. Of course, that was the primary endpoint, but we predefined already a lot of secondary endpoints also to better understand what metabolic acidosis is actually doing and how we can detect it better, or what is happening actually. So maybe in future, now I would say no, we don't have a really better parameter that is available worldwide also. This is still normal acid-base status defined like or detected by pH, PCO2, and bicarbonate. But maybe in future, we will, if we understand more, we will also be able to define better parameters or a combination of parameters. And yes, and the only thing I can say after my study and Dr. Tangri's study is like more philosophical, like Socrates said, I know that I don't know anything actually. So I can't do any recommendations now, because if you would ask me before I planned the study, I would give another presentation as I do now. Because of course you have a hypothesis, and based on this hypothesis, you plan a study. And also, I think also Dr. Tangri did not expect a negative study. He was doing the study because he expected bevacizumab to have a positive effect and the beneficial effect on metabolism. That was also my case, especially because of the basic science I did. And I still would like to break a lance actually for still alkali treatment, because as you said, my primary, let's say, research was in renal tubular acidosis, and we have a lot of patients with inherited renal tubular acidosis, distal RTA, and these patients are severely acidotic. If you would not treat these patients, they will die. They have, as children, they have a failure to thrive. They are vomiting, so they have a bone loss. So I think we have to be a bit more critical, but I think what we can maybe say, and this is already my conclusion, that with the endpoint decline of kidney function, okay, so or CKD progression, there we really don't have a proof or any evidence at the moment to really put the pill burden on the patients and say that this will save your kidneys compared to, as he mentioned, RAS blockade, SGLT2 inhibitors. Now we have, since just the ERA Congress, the GLP-1 analog on top, so, or the mineral receptor antagonist. So I think there we have to be careful. So just to give it to someone to slow down progression of CKD, or for transplant patients, also for prolonging transplant function, probably it's not, we don't have any evidence for that yet, at least. But for a lot of other reasons, probably we would benefit the patients, especially maybe bone loss, and also in patients with RTA and etc. So we have to be more, as in everything now, more precision medicine and individualized medicine than just treating all patients with the same.
So I also want to completely concur with Dr. Mohebbi about patients with renal tubular acidosis. The findings from our study and the other studies before it do not apply to children with RTA and all these other cases. These were not really people in these studies. These studies were people with CKD and metabolic acidosis from low EGFR. So I totally agree with you.
Yes, also CKD patients, for example, with some short bowels, chronic diarrhea, and they have also severe, but they need alkali therapy. So that. Okay, so we have friendly mentioned our paper, so I'm not going to focus on that, but I would also like to explain a little bit how the idea actually developed. So because at that, so it was like 2015 and 2016, and there were already a couple of papers and studies on CKD and metabolic acidosis, and at that time actually most of these studies were positive. And as you mentioned, I had already done a lot of metabolic acidosis, and then I saw also a lot of transplant patients actually, and we realized that the graft survival in our cohorts, so in Europe, where we have the best immunosuppressive drugs, we would say, that are available for all patients, and we have the best, or at least a very good care for these patients, that still we have 75% graft survival only after 5 years, and this is decreasing to 40% after 20 years. And you can see that in deceased donors, for example, it's even the lowest. And in Switzerland, especially, for example, we have still, although we have only a national transplant system, we have quite a long, or relatively long, waiting time for our patients. So this was 2.5 years, which is for us at least quite long. I know in comparison to other countries, maybe not, but still. And we have like this critical mismatch between organs and waiting list, wait-listed patients. And on the other hand, I looked into the data of the prevalence of metabolic acidosis in kidney transplant recipients, and my actually idea was like proven by all these studies that you can see here, that the prevalence is actually higher in transplant patients compared to CKD patients with the same level of EGFR. So you see the EGFR levels, which are quite high, although with a high prevalence of metabolic acidosis. One of these studies is even from Zurich, but the others are from other countries. So on average, I would say maybe something around 30%. And and then there was actually a paper that I'm not citing now from a very well-known transplant group from Canada, and they said that obviously after they did protocol biopsies in transplant patients, and they saw that actually after 20 years, the majority or a higher number of the transplants that are lost are not because of immunological reasons. So because everybody says it's like chronic antibody-mediated rejection that results in graft loss in the long term. However, they were like, at least histologically, they had the feeling that there are also a lot of non-immunological reasons. And I was thinking, so what are these non-immunological reasons? So it's interstitial fibrosis and tubular atrophy. And we know that metabolic acidosis, and these are also has been shown by Dr. Wesson and his group, obviously drives inflammation and also secondary fibrosis due to endothelin and aldosterone. And so all this actually, and then we also looked like into the data that have shown maybe some associations. So here you can see these are only transplant studies. So patients after kidney transplant that has been investigated on the question was either bone metabolism, so effect of metabolic acidosis on bone metabolism of transplant patients, or one study on cardiovascular events, or some studies on graft function and mortality. So we did one of these studies, for example, by our center, but all these studies have been, of course, retrospective and observational. However, if I may show you, so the majority of these studies in transplant patients showed that obviously there is an association between metabolic acidosis and graft failure and mortality. So based on this and the high prevalence of metabolic acidosis and the graft loss on the long term and the CKD data, of course, that have been published, I was really wondering if treatment of metabolic acidosis in transplant patients may preserve kidney or graft function, and therefore the only way to show and to test for this was, of course, to design the study. And the aim was, of course, to test if alkali therapy in kidney transplant recipients may preserve graft function and therefore prolong graft survival. And we were actually lucky because the idea I had quite early, but as usual, there was no money, but the Swiss National Science Foundation decided to fund investigator-initiated clinical trials that have no chance to be supported or funded by industry. And you can imagine sodium bicarbonate is so cheap, is since ever on the market. So they obviously thought that this study is an important study to at least to answer an important question, and therefore funded our study. So we were lucky to plan this investigator-initiated, prospective, placebo-controlled, single-blinded, multi-center trial. So I said by myself, okay, now when we have the money, we want to do it best. So we want to get at least the best evidence that we can for this question. The only thing we didn't do, and I can explain you very well why we didn't do that, we didn't do a double-blind study. That would be even higher because we were measuring bicarbonate. So it was almost impossible to blind the doctor because he was at every visit seeing the bicarbonate, and if the bicarbonate, and there was a rise in bicarbonate, as you can imagine. I will show you the data. So it was impossible. So therefore we said, okay, we do patient blinding because this is important. And we skip the doctor blinding because it's not very reliable. So patients were receiving sodium bicarbonate versus placebo, 1-to-1 randomization. So the average dose that was given was between 1.5 and 4.5 grams of sodium bicarbonate. We also discussed, to give potassium citrate or sodium bicarbonate. We can discuss on every point, and I can tell you also every reason why we chose that, because I discussed on everything with the team, of course, also. And then at the end, you have to decide, of course. So the key inclusion criteria were bicarbonate below 22. Also why did we choose, for example, bicarbonate below 22? EGFR was for inclusion between 15 and 89 milliliter per minute, and the patient had to have a stable allograft function in the last 6 months prior to inclusion. That was defined by less than 15% changes in serum creatinine. The follow-up was 2 years. We analyzed the data by intention to treat, and the primary endpoint was the creatinine-based estimated eGFR or GFR slope over 2 years. And this was actually the question that we discussed most. So I can tell you, I read any study about creatinine measurement, GFR measurements, and to include inulin clearance or not, and so on and so on. So I can tell you also, I will be happy to tell you why we did that this way. And here you see the study visits. So patients were screened, then they had the baseline visit, and then we did a 1 titration visit because, of course, I wanted to make sure, although I didn't know anything about VALOR at that time because it was not started yet, but I wanted to make sure that there will be a difference. So the patients that have alkali treatment are like in the normal range or in the target range or above 22, and the others not. Or so therefore we had the titration visit, and then they were seen every 3 months as like according to their transplant visits, and they had a closeout visit at the end. And I'm going not to complain about that this study has been conducted during COVID. So I was so lucky that I could finish this study without any major, let's say, protocol deviations or violations. So we screened over 1,000 patients for eligibility, and 243 were enrolled. 1 patient was then excluded, so that finally 242 patients were randomized, 122 to placebo and 120 to sodium bicarbonate, and almost all patients were analyzed by ITT. And after withdrawal, 99 patients were analyzed per protocol in the placebo group and 97 in the treatment group. Here you see the baseline characteristics. I'm not going to bother to bore you with this, just to show you that there were no significant differences regarding whatever age, gender, BMI, treatment, history of transplant rejections, and so on. And here you have already the data. So the eGFR slope, that was our primary endpoint, was, you see almost only a blue line. There's a pink and blue, pink for placebo and blue. So they are like overlaying perfectly. And you cannot imagine this shock when our statistician was calling me. She called me, she didn't write me because she knew that and then she told me, I don't see a difference. And I was like really shocked because of course this was not something that we expected. And we were not very happy about it. However, these are the data. And we also looked then into the mean eGFR at every time point, because that was the slope that you just have seen. And also mean eGFR was not different in both treatment groups. But as said, I was so happy when I also got the data for the bicarbonate levels in both groups and saw that there is a significant difference between the treatment group that were significantly higher bicarbonate levels compared to the placebo group with the lower bicarbonate levels. So we, of course, yes, can imagine, then you start to look into subgroups. When you don't have a significant result, you think, maybe some of these patients have benefited from alkali. So we will find out to which patients we should give it in future and to which patients maybe not. So we looked into, as you can see, transplantation vintage, type of transplant. There were some data before that maybe living donor are different regarding metabolic acidosis compared to deceased donors. That was a Korean study. So we looked into immunized versus non-immunized patients. We looked into the different immunosuppressive drugs because we know that calcineurin inhibitors, they cause also a special type of renal tubular acidosis. So the hypothesis was maybe these patients may benefit compared to those not on CNIs. So we looked even if maybe patients that were more severe acidotic may benefit from this treatment compared to the non or less acidotic patients, or patients with a lower eGFR compared to the ones with a better GFR. To cut a long story short, no subgroups that we looked into showed a difference regarding treatment, regarding eGFR slope, if treated with placebo or with sodium bicarbonate. So to conclude, actually, with this study, which was the first, as far as I know, interventional trial where kidney transplant patients with metabolic acidosis were treated with sodium bicarbonate over 2 years. So this treatment had no effect on eGFR slope or mean eGFR levels in these patients. By the way, I meanwhile analyzed also, we measured not only creatinine-based eGFR, we also now measured cystatin C eGFR, and this was also not different, if that would be a question. And however, we have learned also again more and more, because you may have seen data from Hito Hairspring or others also, that obviously the trajectories and the GFR slopes in our patients are different. We have patients that are stable over 20 years in CKD or transplant, and we have patients independent on the primary disease. So these are not patients that have a recurrent maybe disease, but just with normal course where the eGFR slope is declining quite fast. So this we didn't analyze yet, or the study was also not, of course, planned for that. But whether such treatment, for example, has an effect in patients with a rapid decline or earlier stages of CKD can, of course, not be answered with this study. But however, I think this is a very important point that Dr. Heine mentioned and Dr. Tangri. This is actually a citation from an editorial in the Lancet that colleagues have written about our about our study, that 6 pills less, no benefit for bicarbonate supplementation in renal allograft recipients. Ultimately, patients deserve more trials like this, which answer relevant practical questions in daily clinical practice. And that was actually the reason why I planned this study, because I said always I want to have a real world study, because we also know that we can often not use the data from very, very like a homogenized study population, and we cannot translate it into our real world patients, or if we do it, we don't see the same effect. So therefore, I wanted to have a broad range of eGFR. I wanted just to have every bicarbonate below 22 and not to make it too complicated, that if the treatment would show an effect, that a lot of patients may benefit. However, as you can see, the study didn't show any benefit. These are just the organizations that gave the money for this study. Medici actually didn't give money, of course, but they, because we had, you know, maybe how sodium bicarbonate looks like. So it's a huge capsule. I wanted to have exactly the same placebo, so the company agreed to produce for us the placebo exactly looking as the verum, so that this perfectly works. And then, of course, our colleagues from the other centers and all the staff that were involved in the study. And with that, I'm very happy to take further questions and to discuss more about all these interesting findings, also regarding VALOR.
Thanks so much. So I have just 2 comments. Firstly, it's not just 6 pills less, but I guess particularly in transplant patients, this may also increase the adherence to the much more important drugs, surely, like the immunosuppressive drugs, because the more drugs you prescribe to your patients, the less drugs will be taken, surely. That's my first comment. And the second comment, thanks so much for doing this. It's very difficult to do studies in CKD, but it's even much more difficult, I guess, to do studies in transplant patients. We discussed this a few weeks ago with Dr. Alimi from France, Dr. Mortensen from Denmark. We have large fields of transplant medicine like hypertension where we have virtually no data for randomized clinical trials. So thanks so much. But with this, I would like to hear Dr. Tangri's ideas.
Oh, yeah. So I thank you. I first of all, I read your study immediately when I came out, and I think we reached out because this is pre-VALOR results. So we were very interested and excited to see what you've done. Congratulations on the study. I mean, I'm not a transplant doctor, so I don't look. I did some transplant training in my fellowship, but my sense is that once the immune and the episodes have all settled out, a lot of transplanted kidneys tend to behave like CKD kidneys. So I'm not surprised that we get the same result, and I think the 6 less pills really resonates with me as well. So thank you. Totally agree. Wonderful study.
Yeah. But just for example, we were not allowed by the ethics, so I had to do an exclusion criteria. If the bicarbonate goes below 16, then I had to withdraw the patients, for example. So you are so limited always in planning and designing studies, which is a shame because it limits also, of course, all the answers of those studies. But that's also real world. And still, I'm happy. Yeah, I mean, we don't have even proper studies of SGLT2 inhibitors in transplant patients.
Yeah.
So maybe from my side, because we treat a lot of transplant patients, they are maybe more prone to hyperkalemia than CKD patients because of CNIs, maybe intrinsic hyperaldosteronism and so on. Because what Navdeep earlier said is maybe one of the most important findings, that acidemia is maybe not directly correlated to the risk of hyperkalemia. Did you see, because you used bicarbonate directly, did you see that also there was an effect on the potassium levels and less risk of hyperkalemia?
No, actually, I have there also to agree with Dr. Tangri. We didn't see, because we had also a lot of safety adverse events of special interest that we had to declare. For example, blood pressure. So they had 24-hour blood pressure measurements within the study, and we had to. So there was, for example, also no issue with higher blood pressure, with any type of volume overload. So these were all adverse events of special interest. Any hospitalization of heart failure or heart failure episodes, for example, but also no, nothing regarding hyperkalemia in the placebo group. No, we also didn't have.
So in contrast to the 5 pillars that Navdeep previously mentioned, we do not have any of these in transplant patients. We do not have any studies on SGLT2, and I think RAS inhibition is dead. We also did studies with RAS inhibition on a molecular level and showing it doesn't affect the graft and even could be detrimental. When it comes back to the practical point for transplant patients, do you have a lower level when and how to treat? Bicarbonate levels, or are you in this regard nihilistic and a patient with 16 millimoles is also okay?
Are you asking my heart or my brain?
Both.
My heart, still my heart beats for bicarbonate and for alkaline therapy, because I also see a lot of other problems, bone and so on. Okay, but I would agree with Dr. Tangri. So if I have to decide, and if the patient tells me, doctor, okay, I'm okay if I take 5 pills per day, but no more, then I'm going for the immunosuppressive, of course, drugs, and then the cardiovascular if necessary, and not for alkaline.
Mm-hmm. Okay.
So difficult it's for me to say, because, but that's why we do studies, and that's why.
Yeah, of course.
That's it. And I'm also surprised, but I mean, both studies are not the first negative ones. I mean, we had it with hemoglobin corrections. We had it with statins in dialysis patients. So we had already so many. Yeah, no, just a lot of with renal artery stenosis and so we had already.
But in these cases that you said earlier, this needs individualized treatment, because
exactly.
Can benefit for stenting of the renal artery stenosis. Patients can benefit from statins, but they were not included, or they were included because of the statistics. You do not see the effect, but maybe in your study, I think you did it clearly, and we have.
Exactly. I would also not say no to anyone, but you have to really assess. You have to decide. You have to be careful. and consider the whole patient as we have to do.
So we have to treat as physicians with skill, soul, and heart in the future, and not only on artificial intelligence basis. Yeah.
Exactly. So I hope that there will be more data coming from the study. You know, as I said, I have a biobank, which is very, I think, precious and also open. So if you have any questions, maybe, or any of the audience, so we are very happy to collaborate. So we will look more into detail, into a little bit of bone, into metabolism. So hopefully we will maybe also understand that more. Yes.
Thanks so much. This was brilliant, and we could continue for hours, but apparently, well, it's early evening here. It's high noon in Canada, and Dr. Tangri has to continue his work. So thanks so much for doing this study once again. And we're looking forward to reading more from you and hopefully to meet you once again in the future. Thank you.
Thank you.
Thank you.